Thanks, colleagues. Just had some really good discussions at the table talking about all the things that are happening across London, the great joint work that's happening. And this is a really great point to pause and take a look at some of the work that we've got planned to do once for London, Pan-London, and also some of the really good work that's already happening once for London. So I'm going to, I think, kick us off by talking a little bit about the London Mental Health Strategy and what we're trying to do under the banner of the strategy for digitally enabled mental health pathways. And then we've got some really great sessions from colleagues from the One London eMental Health Act programme and also the work that James and Shaz are doing around mental health strategic control centres. So, mental health online. So, mental health online is a concept that is essentially around what would a digitally enabled pathway for mental health for all of London look like. And it's been born out of our London Mental Health Strategy, and I've got a couple of slides here on the strategy just to set that context. I won't dwell too much on this first slide because you've heard a lot of the data already and you know it really well about the treatment gap and the increased demand that we're seeing, the equity gaps that we have in London. The one that we haven't heard yet is around our investment gap, which we know is a challenge. The resources are always a challenge, but the data that we do have developed by the Royal College of Psychiatrists in terms of mental health spend per head of population shows that actually in London we benchmark really poorly compared to other systems up and down the country. So actually all of the ICBs in London are ranked lowest for mental health investment per head of population in London, in England. We know we're not going to necessarily get lots of additional resources over and above what we already have, and everyone's doing lots of thinking about what our productivity opportunities are. So really, we're trying to respond to a problem statement that goes, we have a lot of inequity in access, experience and outcomes. There's a lot of lack of clarity and quite differential access across different parts of the city, and we know we need to do better for our patients. So the London Mental Health Strategy, it was developed by the London Mental Health Board, working outwards with our stakeholders, including our experts by experience, who are members of the board, and also experts out in the systems. Our board is led by David Bradley, who chairs the Chief Execs Group at the Cavendish Square, and also by Zena Etheridge, Chief Exec of North East London Integrated Care Board as well. And essentially, we set out to build a strategy that sat under the banner of the London Vision. So we want London to be the best global city in the world in which to access mental health care and support. And to deliver that vision, we developed 7 strategic outcomes and 8 priority areas of focus. And the outcomes are, obviously, you will see the kind of resonance with the shifts in the 10-year plan. That's obviously purposeful and important. It's what we've all wanted to do for a long time. So we're focused on how we can shift left, prevention and early intervention, how we can make sure access is equitable and timely, how we can make sure we have a consistent core offer so that in terms of principles and outcomes, what you can expect to receive from CAMHS in North East London is broadly the same as South West London, for example. High quality care close to home, very much focused on tackling equity gaps in access and experience and outcome, and with a particular focus on racial inequality that exists in London. Looking at supporting the workforce to deliver really competent, culturally competent care, and importantly, looking at care which draws on innovation, is efficient and is data and evidence-led. So we've got our strategic outcomes and the themes that they're centred around. We have identified work streams to support delivery of those outcomes, and those are very much focused again on children and young people's health, on community mental health for working age adults with serious mental health issues, on urgent and emergency care and that front door offer and support for people in crisis. There's our inpatient quality transformation programme, and we're really fortunate and excited to have in London two sites piloting the 24/7 sort of TRIES model of community inpatient support. We've got a focus on co-occurring substance use. So for many, many years, we have not been providing the care we would like to for people with those kind of co-occurring needs or with complex range of needs. And that's about really embedding a culture of no wrong door across both NHS and local authority commissioned care for people. And then the digital front door, which sits through all data and productivity, and then finally looking at how we can improve our offer for children and adults with ADHD. So how will the digital front door for mental health help with all of that? So as a core enabler, Mental Health Online, our vision is that we have one true digital point of access that sits behind the NHS app, and that gets a patient into the London mental health system to access a range of supports, whether they have more common mental ill health, whether they have a serious mental health need, whether they're in crisis, whether they're a child or an adult. We also, really importantly, want there to be a kind of consistent London offer for wellbeing supports and self-care. So if someone wants to browse the system, is not ready to speak directly with or connect with a service, they can still have a look at what's available. They can still access the kind of broad range of supports that we have already in place in London. We've got loads of resources. We've got the Good Thinking website. We've got, I mentioned earlier, the Best for You service that's been established across North West London and in other parts of the country. So there's lots that we can bring together in a consistent core offer for London through a digital front door. So what we want to do, and we're working with our ICBs and through the London Transformation Strategy, which this programme also sits within, to identify funding, which is already, our 5 ICBs in London have already put aside a certain amount of funding in support of our London transformation objectives. So we're making a case that for mental health, we want to do a pan-London piece of discovery work. We want to work with end users, service users, patients and carers, and with our mental health trusts and other providers across London to look at what you would want from a mental health online service, what that would need to look like. Does the kind of capability and technology exist? We think from our initial kind of pre-discovery work that it definitely does. And there's really good examples already in place in primary care, for example, of AI-driven algorithms, triage, that are delivering productivity gains for primary care, but also meaning that patients get to the right place early. There's less chance of them deteriorating, tipping into crisis, their health getting worse. So we think the technology emphatically exists. Our phase now is that we need to work with you, so all of you guys in the room, our colleagues out in the wider system, to decide what this would look like, who is going to be using it, how they want it to look, and what we would want it to link to in terms of additional platform services and support. So we will be in touch to talk about that as and when, fingers crossed, we get the funding agreed. We will be absolutely reaching out to all of you to involve you in this work. And then moving on to what, in theory, this is a high-level overview of what the system could look like. So the box marked number 1, I don't know how easy it is for you to see from the floor, essentially is the person in London accessing the NHS app through their phone or perhaps at a desktop computer. There's an AI-driven algorithm, which is the central box, and it then will either direct someone to perhaps direct booking to an appropriate service. So someone might say, I'm experiencing some problems with sleep. That might generate the algorithm to recognise that they might be experiencing anxiety. They might end up being directed to talking therapy service. They might answer questions that suggest that their actually struggles are more intense and that they might be in crisis. That could then generate a callback from a crisis clinician based within the crisis lines that we currently have across London. And essentially, it's about getting the right person, the person as quickly as possible to the right service for them, backed up by the directories that we already have in place for a whole host of different VCSE-provided services and supports, and underpinned by a consistent core offer for London across core community services, children and young people services, and so on. And then finally, and the final phase, is we would want to look into, in the next phase, what would a consistent regional virtual treatment pathway for mental health look like? What would a fully virtual digital treatment offer, augmenting current treatment pathways, look like? Because some of the opportunities that could offer us would be around mobilising virtual therapeutic workforce, developing single assessment points potentially for specific conditions. So thinking particularly about the pressure that systems are experiencing with adult ADHD at the moment, for example, you could envisage a future where you actually just commission one service to undertake assessments for adult ADHD and signpost people appropriately into the right care pathway depending on their needs, which will vary in intensity and severity. And we also think that the model that we develop could have national scalability. So we're in conversation with the National Director of Transformation, Vindvaker. We want to make sure that London can be a kind of test bed and innovator for this work, and that we can capitalise on future opportunities for London in this space. We're not aware that anyone else is looking at this yet. We know from I read in the press today when the new prevalence information came out that the kind of teaser about the long-term plan was exactly this, that it would look at digitally enabled pathways for mental health. We know from our engagements nationally that we're not aware of other kind of systems up and down the country looking at this at scale across London. And I guess just referring back to my earlier presentation about how London's so well placed to take forward transformation in this way, I think it's a really great opportunity for us to be leaders in this space, but it's really, really important that we work with you all together to get it right. And I'm just going to leave, I'm not going to go into these questions now, but it's something that I want to kind of engage with, we want to engage with you going forward, is thinking about what some of the opportunities could be for us in developing a service like this, how we overcome the challenges, which there of course will be challenges, which pathways or groups of patients should we look at first in terms of the design, and anything else that you think we should consider, or anything else that you are already doing that you think is a really good fit for this space. I'm going to leave it there, so thank you very much. And I think I'm going to hand over to Joss and Peter to talk about eMental Health Act, and then we'll have time for questions at the end. Thank you.
Hi, everyone. So I'll introduce myself, and then Peter can introduce himself, and then we'll get cracking. So my name's Joss Palmer, and I'm the Programme Director for One London. I'll explain a bit more about what that is as we go. So this is what we're going to talk about and share with you in the sort of next 10 minutes or so that we've got. So I'll just share a little bit about what One London is, and then we'll both talk about the work that we've been doing on digitising the Mental Health Act with some of you that are here in this room as well. And we'll share some of our lessons and learning, and then I guess if there's time for questions now or afterwards, then we can pick that up. So first of all, I guess just to set the scene for One London, this is something that you will all know, and so I won't kind of labour the point here. I think we all know that we've got these organisational boundaries, and we've got organisations that run different sorts of electronic patient record systems or care record systems, and those systems really don't automatically talk to each other, do they? So I guess what we can see is we have silos of information between different sectors, but also even within a single organisation. So we think that there are around about 24 different electronic patient record types in London. Your Epics, your Cernas, your EMIS, your TPP, your Rio, Liquid Logic, etc., etc. And obviously that doesn't count some of the more specialist systems that are used in some organisations. So that's a bit of the kind of, the backdrop and the complexity that I'm sure is very familiar with many of you. So in terms of what One London is then, really it's a brand that we use when we are talking about collaborative work that we're doing at scale across London, so working across the 5 ICSs. It's not just one programme, so it's a range of different things that kind of use the brand, if you like. So just to touch on some of the things that you might be familiar with, we've got something called the London Care Record. That's a shared care record. It's based on the Cerner or Oracle Health Information Exchange, HIE. It's used about 2 million times a month plus. Now about 100,000 staff have got access to it. It's not perfect, but it is something that we've got in London. We've also got the Universal Care Plan. That's Read Write, so it's actually a collaborative care planning tool, and that was introduced a couple of years ago, specifically around sort of end of life and urgent care, but it's been expanded now, so it's been really well used in sickle cell, and then other areas are sort of moving on. So, for example, with learning difficulties, frailty, etc., etc. And actually, we're having some conversations about could it be a useful platform platform to support crisis plans. EMHA we'll be talking about today, and we've also got something, the Transfers of Care, which is about London Ambulance and just supporting that digital transfer into Trust EDs. And there's a big programme of work which is all about health data for research and how do we collaborate across London to do that. So I'm sure some of you have used some of those systems and or you're probably involved in some of those programmes. But at the heart of it all, it's about working at scale, working together, trying to make the best use of our resources, and just thinking about the reality of the fact that very many Londoners live in one part of London and receive care in another, so we can't be too tied to our organisational or ICS boundaries. Do you want to?
So I'm CTO at East London Foundation Trust, and we were already using an EMHA system, Thalamos, so we're sort of naturally well placed to help kind of lead on this. Now, if you wanted to pick something that has quite rigid processes and everybody's supposed to know what they're doing in quite a specific order, then you might pick the Mental Health Act and think that was an easy target for something to do across London. And I think one of the lessons learned is that even something like that is incredibly complex to do at scale across multiple organizations. And also, I think, just to talk a little bit about the program, we actually went through an initial phase of, I think Hassan used the metaphor earlier on of if you try to eat the elephant whole, then it'll squash you. Well, it didn't squash us, but it did sort of stare at us for a while, wondering why we were trying to eat it. And it took a bit of a reboot to get the programme going. So initially, the plan was to get all the London Trust to commit to doing everything, the local implementations, and then all of the kind of important pan-London stuff. And I think that reboot understood that kind of the level of complexity of doing something like this required us to do the slightly more straightforward, although still complex thing first, of getting the London Trust respectively to go live with the system locally and understand it and use it and adopt it, and then break out into a phase two for the kind of the pan-London work that required not just collaboration, but also kind of really understanding what we needed, what the priorities were, and how we would try and achieve them. So that's where we are kind of part way through at the moment. We're coming towards the end of the phase one. Elft went live the end of last year and are now pretty much into sort of business as usual. Our adoption it's really pretty good. The new system, it's about 90%. We did 900 of 1,000 Mental Health Act processes on the new EMHA system last month. And so Nelft followed pretty much straight after, and South West London, St George's, Slam, Oxley's also now live. And I think it has been... This is the first time that I've been involved in something pan-London like this, and I think one of the things that I've come to appreciate is just how much effort, coordination, momentum, work, structure, plugging away is required. And I think that wouldn't have been possible without the kind of One London programme, which hasn't been perfect, but has done a lot of things that wouldn't have happened otherwise and has moved the needle. I was, of the multiple work streams, I guess, one example would be I was probably most closely involved in the clinical safety work stream. There was one safety case commission that was then localised to each trust. I think that would have just been so much more burdensome had each trust been expected to do that individually. And so trusts have retained a degree of responsibility, which might be seen as onerous in some ways, but I think has also provided confidence that each trust has had control over exactly what they would and wouldn't do and how they would do it, and made it more possible, along with kind of rebalancing the financial commitment to feel that it was something that trusts could invest in. And like feedback so far has been positive in many ways. I think positive from clinicians' point of view, that actually the system works well, the interface is good, it helps avoid errors, it helps people enter the data, it helps people communicate. People actually like using it, but it's not perfect. One of the things that we're currently working on is one of the main gains that is anticipated is that it will help mental health law teams have a much better oversight of mental health act processes, avoid delays, make sure everything moves more quickly. But as you move from old paper-based processes onto using a new system, and people are still emailing some forms, and that kind of dual or even triple running can be quite onerous on mental health law teams. But as Doug said earlier on today, in a kind of taking a user-centered design approach, what the Pan London programme, what One London is doing is going in, seeing how mental health law teams operate, identifying the working practices, coming up with, I think they've got 50 pain points, stratifying those into the ones that could be system design, the ones that are more to do with process, perhaps more to do with training and education, and kind of trying to work through all of those issues to help everybody in turn. So I think that's the other advantage of a centralised programme, is that you can kind of help each other out, take some of the kind of pressure off worrying about, am I doing it right or wrong, who can I go to, and kind of share the learning, and that's been really valuable. So yeah, that's where we are at the moment, boosting adoption across the trusts, kind of trying to continuously improve the interface in that kind of a way, and then looking to this phase 2 of kind of big, chunky pieces of development that will start to enable some of the kind of pan-London benefits of EMHA. So that might be sharing up Mental Health Act status to the shared care record so that you can know if a Mental Health Act assessment's happening somewhere else in London, and that would provide more appropriate, effective care to somebody. Integrating with the police's app so that paperwork doesn't get lost at the point that somebody's handed over from the police to a place of safety. Integrating our electronic prescribing systems so that you've got the Mental Health Act paperwork there present, actually looked at the point at which you're doing prescribing and administration, so people don't get treated illegally. There's lots of ways in which these phase 2 integration works will have meaningful benefits, and that's what we're sort of trying to prioritise, negotiate, better understand. I think that's the other thing we were talking about, business cases over there. It's hard to know some of this complexity until you're already in the middle of it. So to put a business case together at the beginning that articulates the stuff that we're still now discovering seems almost impossible, which is why sort of the central backing to move a complex piece of work forward is essential. So yeah, I think I've probably already said my lessons learned as we've been going through. I think that central drive to deliver at scale is essential. I think balancing the aspirations for something that is inevitably more complex than you thought it was with the pragmatism to actually push things through and move forward, even if it's not the immediate sea change we're looking for, is important. Joss, do you want to come in? Yeah.
I'll sort of like chip in. I think a couple of the other learnings that we've had sort of programmatically has been about that it has been really important to have some clear work streams because I've been working across a number of trusts in London, and we have brought in some support and expertise from outside to help us as well. So Peter talks about clinical safety. We also had somebody to come and help us with information governance and also in terms of leading some of the technical work. And I think we felt that that was broadly positive. And I think to give an example, I think with some of the other One London programmes I work on, IG, information governance, it's a bit of a nightmare, and quite often the conversations go round and round and round with all the reasons why you can't do something. Whereas I think what I saw with this was just a really well, like treating it like a mini project almost, so super structured, focusing on just getting on and doing the job, and I think really building some trusted relationships by the collaborative nature in the way in which the work was done. So it took a lot of the drama out of it really and just helped it to progress fairly smoothly, and certainly it didn't stop the go-lives. I think as well, we've done some limited integration with the Rio EPR system, but I think we certainly found that we needed more time and probably a bit more money than we thought we would have needed to begin with. So I think that engagement early, and those were kind of really practical things that if we were doing this again or doing it in the next stage, we would want to replicate that for sure. Is there anything you'd like to chip in terms of more lessons?
No, I just think that it has established some relationships and shared understanding of how difficult it is to get stuff done and how much it's essential to work together that will feed into whatever comes next. I think it has had value for digitising the Mental Health Act, but I think it's hopefully also had value for what would we do the same and different next time.
Thank you, yeah. And I guess I often say with some of these One London programmes that we can only move at the speed of trust. And I think there still is, some areas where we need to build a confidence and where we need to deliver. So there's more work to be done. We're not at the perfect nirvana point yet, but I think we've at least started this journey to digitise. And just to wrap up, if anybody wants to follow us, get newsletters, keep in touch, then please do. Those are some contact details, and you're welcome to kind of also just contact me personally if you'd like to know more about One London or about this programme. Thanks.
Thank you.
Conscious it's Friday and everyone want to go home, but I think we've got one session after this. So I'll keep it brief and then hand over to James. So this whole concept, I think, came about when I was doing a presentation for my boss, Luke Redmonds, the Director of Digital Transformation. I was trying to find a graphic in which I could demonstrate the different elements and different programs of work within digital mental health in London. And I found one which fit in neatly. It was a jigsaw one, which James will show on the screen in a minute. And from there, James and I got talking, and we thought, if we can put all of this on a PowerPoint, what if all the different systems, whether they're trust-based or the pan-London ones, or even the ones that transgress our sort of regional boundaries, we could bring them all together. At that time, think about 2 years back, we thought there's not enough digital maturity. Many of the systems are still maturing, they're in their infancy, but now we feel it's the right time when we can bring all the systems together so we can have one big system of different systems, and all the data that it generates could provide that insight and help us basically to do one thing, which is to run away from doing the firefighting and scrambling on a weekend and on a regular basis, and be more proactive and do more planned work than we've ever done before. So I'll hand over to James, and then we'll take some questions at the end.
Thanks, Shaz. Okay, so we want to start with just this plain model of how, turning actionable insights can help plan resources to improve health outcomes and efficiency. That's the general theme of what we're going to talk about. And I want to just start by saying the only reason we're presenting this is because of the work that you've just heard about. The Mental Health Act Online, the interoperability that we already have, Emma's presentation on mental health online. This is the 10-year plan. This isn't a tomorrow plan. This is definitely in the 10-year plan. This is pushing our expectation of what we can achieve together based on that level of trust that we've started to establish through programs like the e-Mental Health Act. So a colleague was talking earlier about supermarkets. In supermarkets, they absolutely mine every piece of data. How often certain items get bought, what the relationship is between the temperature and the items. So supermarkets know that if the temperature gets to 24 degrees, they're going to sell 15% more ice cream, so they order that in. They can see that through their predictive modelling. They don't just ingest their own data, they ingest, the Met Office's data as well. And that's why when you walk into the supermarket on a hot day, they have enough ice cream. Well, hopefully that should be the case. Now, what they have is different levels of predicted modelling. They have, if you like, patient-level modelling, which is their loyalty card data. So every time you buy something and you scan your loyalty card, it tracks what time of day you bought it, it tracks exactly what's in your basket. They can tell what your cholesterol level is, probably better than your doctor, based on what's in your supermarket basket. So they know you as an individual customer, and they know you over a long period of time. Many of you probably shop in exactly the same supermarket week by week. But they also look at that population health data. They look at individual store data. They look at clusters of stores in geographic areas. They can mine that, whether it's Met Office data, socioeconomic data, and they can start to do that high-level population management. And I guess that allows them to really deliver a great customer experience. They know what you're going to buy before you even come into the supermarket based on all of that data. We have the potential to create something different. And this is the jigsaw, right? We've heard about some of these jigsaw pieces together. EMHA platform, One London, our health information exchange, online NHS 111 hubs, our workforce data, our smart bed management tools, our EPR data. How do we start to put these together into our model of both system-level population predictive analytics and that patient-level data. Because we often just talking about one. Some colleagues in, I think, ELFT are looking at MAST, which is a predictive analytics tool, certainly very lot of interest since the Nottingham investigation, looking at these predictive risk analytics. But actually, that's only one piece of the puzzle. We need to be thinking about the shared systems intelligent approach that allows this proactive planning and operational delivery. And what does that look like? And then we start to combine it with a kind of new graphical visualization technology where we can start to visualize this in interactive, easily usable ways, mapping that data geographically. So what we're suggesting is that over the next 5 or so years, we can really start to work together on building this radar system that helps us manage the care space of mental health in London. Now, they are starting to try and do some of this in our acute settings, and that's where this kind of system coordination or system control centre. But there is a level of digital maturity that we need to understand. And the potential is huge. We can get into that advanced predictive analytics around individual patient care and aggregate that up into our high-level predictive analytics. So we can see the demand. And you talked to Geraldine Strathdy, the previous National Clinical Director and previous Director for Mental Health in London. And during the Olympics, apparently they had all this, and since then we got rid of it. So when you talk to Geraldine, we were actually just reinventing what they had in 2012. Don't know how true that is. Sometimes Geraldine is known for a bit of hyperbole. And I say that having worked with her for a very long time. Responsive, we can get into that really responsive care coordination, predicting that demand on A&E, that demand on our mental health EDs in that sense. We can look at those outcomes and hopefully reduce costs over time. I do think it goes back to the point that Shaz made earlier, which is who pays for this. If this is not going to only benefit mental health system, but benefit all of the system in London, who's got a stakeholder investment in this? So we need some foundations. Standardized data. We heard about the Mental Health Act. It comes with a degree of standardization, and we've had conversations today about unlocking the value of our data, the compromise that we're prepared to make in order to standardize the data so that we can get this value out of it. We need to integrate our systems. We need to wrangle our suppliers together so they share this data. We need to work together on commissioning these platforms rather than commissioning them 8 times or 9 times or however many times we want to commission it. And we need the best data visualization. We need to invest in, and we talked about this earlier, data analytics. We need to recognize that actually sometimes employing people in data services is actually more valuable than employing one more clinician. So, working towards the future, this is just a suggestion of where we want to get to, and maybe in future Cavendish Square digital events we can build on this. This is a 5 to 10 year mission, so let's agree this shared vision. Let's continue to invest in those jigsaw puzzle pieces, focused on that standardization to improve interoperability. And then finally, it's, let's think about how we can improve that digital maturity across our trusts, that supplier management and the scaled up implementation. We haven't got all mental health trusts in London on EMHA. That would be a good step next. And I think that's it. I think we're gone on to the next session.